Hello and welcome to our listeners around the world. You're listening to the JAMAevidence User's Guide to the Medical Literature podcast. Thanks for joining us. I'm your host, Dr. Gordon Guyatt, Professor of Medicine at McMaster University in Canada. And today I'm joined by Dr. Mark Wilson, Professor of Medicine at the University of Iowa, Associate Dean of Graduate Medical Education. Welcome, Mark.
Thank you much, Gordon.
So today we are going to be talking about one of the chapters in the User's Guide to the Medical Literature, which differentiated between evidence-based practitioners and evidence-based medical experts. Mark, can you clarify that distinction?
I think a big piece to keep in mind is it's about how we individually aspire to practice in a more evidence-based way and how we inspire our learners to choose wisely for how much to grow their evidence-based clinical practice skills. On one end of the spectrum, the evidence-based experts are those that have very deep understanding of clinical epidemiology, study designs. They're able to find, interpret, and apply best available evidence to drive clinical care decisions, sometimes on a one patient at a time basis, but also within health systems. Evidence-based practitioners may be a way to refer to our colleagues who are more interested in how do I rapidly access evidence-based summaries and interpret them. Oftentimes those summaries come with recommendations. Sometimes they're just very dense chocolate torte kind of rich desserts that have really already done the critical appraisal aspect and are then providing the measures of importance or effect to help them understand how to deal with a certain diagnostic issue, a therapeutic intervention, counseling about prognosis, etc.
Who can become an evidence-based practitioner? Who can become an evidence-based expert?
One way to look at your question is any motivated clinician can pursue either approach. Importantly, they should choose one of those big general categories. For those that are aspiring to develop more expertise, there are oftentimes individuals that have unlimited amount of curiosity and are very keen to develop skills to be able to become a leader in their future clinical practices.
What are the skills required on the lower level, if you want to call it that, evidence-based practitioner? What are the minimal skills?
I believe that there are a lot of skills that the evidence-based practitioner needs to develop. They range from being able to recognize their knowledge deficits during patient care. They need to then translate that uncertainty into a specific clinical question and then be able to tie that clinical question to an evidence-based summary, and then importantly, be able to interpret what is in it. Again, as I briefly mentioned before, sometimes these lead to a single recommendation, and that can feel very comforting. The piece that I think is still very important for evidence-based practitioners to develop is facility with being able to interpret magnitude of effect of a absolute risk reduction or of a likelihood ratio. So then they can still wisely keep growing their ability to apply this clinical evidence to the individual patient that's in front of them.
How are they going to pick up all these skills?
Ideally, it is through their medical education that starts during medical school and intensifies during graduate medical education. And then ideally, it is continued to be refined throughout their clinical practice, whether that's in a community-based setting or in an academic teaching setting. So it is about starting a journey. It's about, during medical school, I like to tell the students, it's about taking the first step on a staircase. It's not about being able to visualize the entire staircase yet.
So it sounds like they had better be in a place where their medical education and their residency is paying attention to providing them with the education they need to pick all this up. Is that right?
I believe that's critical. There are individuals that are able to be on, in essence, a desert island related to evidence-based medicine and evidence-based clinical practice, and are able to pursue on their own how to chase their curiosity without that. But goodness, it doesn't have to be that hard. It should be integral within their medical school courses, as well as, importantly, during graduate medical education, the emphasis on caring for individual patients.
So, do you have a sense of what expectations people can have as to whether, even within the United States, they're going to be exposed to what you need to become a good evidence-based practitioner?
I think it's very important to acknowledge the dynamic tension that always exists, because most of our medical centers are incredibly busy. Most of them at this date are understaffed in various ways. And so then it has a tendency to decrease some of the handcrafting that's needed, whether it's for bedside physical exam skills or it's about how to judiciously apply best available evidence to an individual patient. So I think it is important to acknowledge that's a reality. So it's a reality. It's always been that way to a degree. It's on us that are involved in academic medical centers to find creative ways to help the residents and the medical students see the power of being able to learn enough about the best available evidence to have a informed conversation with a consultant. That's one of the ways that I've seen a lot of folks' eyes brighten up when they think, well, I won't just ask why of the consultant. I'll engage them in, I just looked at the latest Cochrane review, or I found a good article about the test performance characteristics of this diagnostic test you're recommending. X, Y, or Z is what I found. And then they can feel like they're interacting more as a colleague as opposed to someone taking a recipe from a similarly busy subspecialty consultant.
And it sounds like to get to that point where they're comfortable doing that may require more initiative in some institutions than in others. Is that fair to say?
It's always affected by culture. In fact, I think one of the challenges that always exists is local experts can have very strongly held opinions that sometimes don't evolve at the same pace that the medical literature is evolving. Again, I'm as fallible as they are. I'm a general internist, and it's important to recognize that the local culture very much also affects how our learners and how our patients then are engaging with discussions about how to apply best available evidence for their clinical problem.
And it sounds like variability in those cultures is appreciable, even within the United States, and certainly listeners in other places internationally will have to understand what their particular culture is and the challenges that they face in becoming competent evidence-based practitioners.
I agree.
Once you have set yourself the goal of being an evidence-based practitioner in the way that you have described, how should you monitor yourself in terms of deciding whether you are successful in your goal of providing evidence-based care?
There are a variety of ways that folks have looked at trying to give feedback to clinicians about their practice habits. And so audit and feedback, or one that I think is also a very powerful intervention, is related to academic detailing, of which is having a content expert have a one-on-one conversation with a clinician. Both of those, however, are also at risk of not being done consistently enough or not being applied to high priorities where the healthcare delivery system sees there's excess variability that may be impairing the quality of care that individual patients get. I think as much as I have a love-hate relationship with the electronic medical record, whenever I'm in clinical settings, it's also an incredibly powerful tool that ideally can increasingly help healthcare delivery systems identify what are those areas that are seeing the most excess variability, and then to locally decide what approach to behavior change do we want to emphasize.
We've been up to now mostly speaking about the individual and the individual, how they can get to be an evidence-based practitioner, how they can develop the skills, what those skills are. But you just shifted to an extent from a systems perspective, because from the systems perspective, presumably what we're trying to achieve is evidence-based care. So from that systems perspective, I think you just suggested one thing which you can reiterate, but anything else that could happen at the systems level to optimize the likelihood of evidence-based care?
A couple of things come to mind. I think it's very important for healthcare systems to involve frontline clinicians in looking at the data, interpreting the best available evidence, and engaging in conversations about how to make a change. So, healthcare systems that try to make it just top down, I think, are destined for less impact in this area. I think the other piece that is continuously at risk as we interact with patients and learners is that we forget to emphasize how important tailored, judicious application is to individual patients. And that's really where the magic happens. And sometimes there's so much urgency on what is the best evidence, and oh my goodness, it's continuously changing, and there's new types of study designs that we need to interpret, whether it's non-inferiority trials or network meta-analyses. There's always a lot that's going on, and sometimes a lot of the emphasis is put in those early phases of trying to understand what is the best evidence, and then there's relatively less traction at the interface with patients. And I think healthcare systems of the future that are wisest are those that are going to really emphasize that aspect.
Very interesting. If I've got it right, it's the emphasis on what we sometimes call the third principle of evidence-based medicine, is that evidence never by itself tells you what to do. It's always evidence in the context of patient values and preferences.
I agree.
Okay, great. Very nice explanation of the world of evidence-based practitioners and evidence-based experts and how they interact with the systems in which they work. Is there any final comments you would like to make? Anything that you'd like to add from what we've discussed thus far?
First of all, it's been delightful having this conversation with you. It is at the crux of what those of us that want to make a difference in future clinicians wrestle with regularly. We need to be able to help our learners make informed choices of where they spend their learning efforts. And I think at times it is really important for them to recognize, at this juncture, I think I need to emphasize more my practitioner skills, if you will. And at other times, I may emphasize going deeper into pursuit of expertise. I think the other key pieces for all of us is to remember that healthy skepticism throughout our careers as clinicians is necessary, as well as humble curiosity, because at times we regularly need to unlearn something that we previously were very comfortable with using in clinical practice.
I'm Dr. Gordon Guyatt, and I've been speaking with Dr. Mark Wilson about evidence-based practitioners and evidence-based practice. You can find a link to the article in this episode's description. The episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at JAMAnetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.